Hello and welcome. It is a great pleasure to welcome you to this webinar, which we are recording live from São Paolo in Brazil. The title of the webinar is Translational Advances in the Management of Growth and Puberty Disorders. Let me introduce the faculty. My name is Martin Savage from London in the UK. Professor Alexander Jorge comes from the Department of Internal Medicine at the University of São Paolo here in Brazil, and Professor Claudia Latronico also from the Department of Internal Medicine here in the University of São Paulo in Madrid. And it's a privilege to be able to have Alex and Claudia with us. Both are highly experienced academic doctors in endocrinology and genetics. So here are the learning objectives. After taking part in this webinar, it is our objective that learners will be able to, first, explain the recent genetic advances in growth and puberty disorders. Second, explore how genetic advances can influence and improve the diagnostic and management approach to growth and puberty disorders. And third, to interpret the clinical presentation of central precocious puberty to determine the best therapeutic approach. So here we have the agenda, and I'm not going to read out all the agenda. You have it on your screens. After this short introduction, Alex will give two presentations related to the genetics in pediatric endocrinology and also then specifically in growth disorders. Claudia will follow with genetic contributions to abnormal puberty. Alex will then come back and talk about therapy of short stature, genetic influences, and Claudia will give the final presentation on the management of central precocious puberty. Throughout this webinar, we invite you to answer the polling questions. These are multiple choice questions, which you will see come up on the screen. And we also ask you to post questions, ideally in English, and we will cover your questions in the discussion period at the end, and possibly, if they're relevant, to individual presentations. And in order to post questions, you will find the place that you do this just under the screen that you have in front of you. It's important to announce that this program is made possible thanks to an educational grant received from Merck KGaA Darmstadt, Germany. So here are some pre-assessment questions, and we ask these at the beginning of the webinar and again at the end, just to see how effective we have been in increasing your knowledge of this topic. So the correct answers will be revealed at the end of the webinar, and these are the pre-assessment questions. I'll just read out questions 1, 2, and 3. You have a number of options, and we appreciate that if you do not know the answers yet, there is an option to say that I'm not sure. So question 1, for genetic diagnosis, a candidate gene approach rather than whole exome sequencing should be used. So we'll give you some time to fill out the answers to these questions. Question number 2, which of these situations listed below suggests a genetic growth or puberty condition, a genetic growth or puberty condition? And question number 3, which condition listed below is significantly more prevalent in patients with central precocious puberty and a DLK1 mutation. So we'll give you a few minutes to answer these questions, or a few seconds rather. It shouldn't take. So we'll ask these questions again at the end of the webinar. And now it gives me great pleasure to ask Alex to give the first presentation entitled Advances in the Genetic Diagnosis of Pediatric Endocrine Disorders. Alex.
Thank you, Martin, for this kind introduction, and for you invite me in the Springer to launch this project. That's very interesting. Here my disclosures. In this first talk, we will show the evolution of genetic as investigation tools for short stature patients, and we'll try to answer the question that what questions can genetic investigation answer, which test should be requested, a candidate gene sequence or whole exome sequence in each situation, and how to interpret the result of a molecular genetic test. A genetic disorder is a disease caused by a change from normal DNA sequence. You can find deletions, duplications, or point mutations. The traditional genetic approach is based in a candidate gene that is chosen by phenotype of the patients. And you can use techniques that are assess copy number variations like MLPA or FISH, and the techniques that assess point mutations like traditional Sanger gene sequencing. This traditional genetic approach have the problem that a specific genetic molecular study, protocol, and technique is required for each disease and gene. This causes an increase in the cost and the timing of each study. There is a low level of documentation, and for this reason limits the number of genetic tests offered, but especially for commercial laboratories. This traditional approach is especially difficult for disease with large genes or multiple causative genes. In this sense, genes with low frequency of affected are usually not investigated, and the rare disease are usually not diagnosed outside an academic environment. For this reason, in the last 10 years, there is a development of a molecular genomic approach and several techniques that assess a global analysis of the genome. For copy number variation, chromosomal microarray analysis, CGH array or SNP array, it's the classical technique to assess deletions and duplications, even submicroscopic ones, larger than 30 kilobases. And more recently, massive parallel sequence, also known as next generation sequence, allowed whole genome and whole exome sequence. The next generation sequence gives the possibility to sequence the whole genome, but this is a lot of data and means a lot of regions that do not codified protein and usually difficult to interpret. For this reason, for clinical basis, usually it's used a whole exome sequence, that means a part of the genomic code that codified protein and where the majority of causative variants of disease are found. This means 1 to 2% of the whole genome. And we also use the target panel sequence when you choose only some genes from your special disease or interest. Well, when choose genomic or a gene candidate approach, well, when you have a specific clinical diagnosis with a high probability of only one or a limited number of causative genes that explain a large percentage of patients with these conditions, the best approach is target one, like hypochondroplasia, that mutations in FGFR3 is explained around 50 to 80% of the cases. But conditions with a high probability of being genetic, but is not possible to determine a candidate gene because they are very rare conditions or have a complex clinical presentations, or there is a lot of non-specific findings, like children with short stature and intellectual disability only. Whole exome sequence, a more genomic approach, it's better to achieve a genetic diagnosis. When you know the candidate gene, but they explain a small fraction of the genetic cases, you can use a target gene, but usually the result is usually negative because this, what we know already about that disease explain only 5% of the cases. And for this reason, a genomic approach can allow to reanalyze several times after when your knowledge improved about that disease. And how to interpret the result of a molecular genetic test. Usually, all the genetic tests should be classified according American College of Medical Genetics. When the variants identified in the patients are evaluated according the conditions and the inherent pattern of the patients. These variants can be classified as pathogenic, like benign, or uncertain significance. Depends of population data, functional analysis, segregation of the variant in the family, in silico and predictive data, and type of the allelic data, or that means the genotype you found, homozygous or compound heterozygous, and information from genetic databases that collect the information of other patients analyzed for the same conditions. The positive pathogenic findings is easy to interpret. But what does means a negative result? Well, the negative result don't mean that the condition is not genetic, because sometimes the causative variants are not being identified due to the limitation of the method, or non-recognition of the variant as pathogenic, like a variant that didn't change the amino acid. Or the causative variant is located in a gene not yet associated with the phenotype, and the causative variant can be also located in a not assessed region, like intron. For this reason, it's quite often when you go to a genomic approach like whole exome sequencing, the reanalysis of the data can give a positive result after a while. Like in this study in 2013, they analyzed almost 2,000 individuals using whole exome sequence and give a percentage of positive finding in 1/4 of the analyzed cohort. After 3 years, they reanalyzed the same data that was produced in 2013, and more 11% of the cases can now be recognized a pathogenic condition. Most of them because new genes are associated with that patient conditions. Of course, a negative result can also mean that the investigation condition is not genetic, maybe epigenetic or environment, and then you have to be always this in mind. But the majority of data that are produced by whole exome sequencing are variants that are classified as uncertain significance. This variant, or we call VUS, should not be incorporated in the clinical decision make. And the time when you reanalyze the family segregation or go to functional studies or more population evidence, you can reclassification of this variant. And when this occur, the majority of VUS are downgraded. That means that they go to VUS to like benign or benign. So after I finish this first presentation, I'd like to ask you to know your knowledge about and your feeling about the subject, that regarding the request and the interpretation of genetic tests, which of the following reflect your knowledge? You can choose, there is no right answer, it's only to know your opinion.
Okay, Thank you very much, Alex. Beautiful introduction. And of course, molecular genetics has really changed the landscape of endocrinology. And one of the fields in which most contributions have been made is in the fields of growth disorders. Growth disorders are the most common disorders referred for a pediatric or an endocrine opinion. And so we'll go on now, and Alex is now going to give his next presentation entitled Investigation of Growth Disorders, Genetic Contributions.
Okay. Thank you again for this opportunity. This is my disclosure again. Well, now we will try to answer the following questions. How do genetic investigation fit in the diagnostic assessment of short stature? How can genetic data improve patient care? What point in the history should be noted as being suggestive of a genetic defect? And which children should be tested? Why genetic test is so important? First, because it's able to establish a etiological diagnosis. And for this reason, they decrease the number of medical procedures in the diagnostic investigation. And after you have an etiological diagnosis, you can improve genetic counseling and allow a rapid recognition of other affected cases in the family. In some cases, the genetic diagnosis can predict the patient's or disease evolution, allowing a more adequate follow-up and guide the use of medications in pharmacogenetic way. Well, short stature is a very common condition. More than around 2.3% of all children have a height standardization score below -2. Usually, we are aware that there is several chronic systemic diseases that can drive a short stature, but the majority of the conditions that the majority of children have that explain the short stature are not a chronic systemic disease, and are usually have a genetic component, like a syndromic short stature, Turner and Noonan syndrome, or skeletal dysplasia, or even children with isolated short stature when they have a family of short stature. In OMIN database, you can find more than 1,000 conditions that are related to growth disorders. It's almost 12% of inherent genetic disease. And we have to be aware that not all these conditions are genetic. Some of patients that have syndromic short stature that fit that classification in OMIN have environment conditions like fetal alcohol syndrome or epigenetic conditions like Silver-Russell, but the majority of them carry genetic conditions in patients with syndromic short stature. But it's very important to aware what find is strongly suggested genetic conditions. So a specific clinical diagnosis of conditions with non-genetic basis is the major aspect. Of course, when you have consanguineous parents or patients that come from genetically isolated populations that have a potential to have a consanguineous, this increase of a recessive disease, or when you have a clear dominant autosomal inherent pattern, this increases the chance of autosomic dominant conditions. Syndromic phenotype, due to the presence of dysmorphic face features, major malformations, development delay, and or intellectual disability, also increase of the chance of monogenic conditions. And the more severe short stature, height standardization score below -3 in relation of the populations or in relation of parents also increase the chance of to find positive genetic conditions. We also need to try a genetic candidate gene approach always when it's possible. Like this girl that have a disproportionate short stature showed by the increase of sitting height, total height standardization score. And because she have an aunt that have a Madelung deformity, these patients have a disproportionate short stature, autosomic dominant familial inheritance pattern, and a member of Lero-Weil dyschondrosteosis that trigger the gene candidate is shocks. And you know that 2/3 of patients with these conditions have a deletions of shocks gene or regulatory regions related to this gene. And the MLPA is the first test to genetic assess this family. If it's absent, you can go to the Sanger sequence to find point mutations. This is a typical candidate gene approach. But we already know that patients with short stature, especially girls with short stature of unknown, unexplained growth fail, should have assessed by karyotype, common, or chromosomal microarray analysis for the possibility to be a Turner syndrome. Besides the fact that less than 2% of these girls with isolated short stature have Turner syndrome, the diagnosis have important consequences because when you establish the etiology of short stature, Turner syndrome allows to initiate a precision medicine, treatment with growth hormone and induction of puberty, as well as specific multi-system investigation and treatment. And to give a glimpse of what we are talking about, the impact of the etiology diagnosis in a cohort of short stature patients, we want to share two of our recent papers that assess by whole exome sequence and the panel a cohort of children with a syndromic short stature and children with isolated short stature that born small for gestational age. In this cohort, almost 90% of children that have clinically recognized short stature syndrome, we confirm by a genetic analysis. And in those syndromic short stature children that have unrecognized conditions, in almost 1/3 of them, we established etiological diagnosis using whole exome sequencing. And even in those children with isolated short stature, that means that have only short stature at the phenotype that trigger genetic investigation, 15% of them we found monogenic conditions. But we have some concerns related to molecular genetic testing. They can use, genetic tests can cause stress and anxiety in the family about the test results. Parents carrying a gene mutations usually feel guilt about the child's disease. Usually there is a disproportionate expectation of the result, which causes frustration. And due to technical limitation, a definitive conclusion sometimes is not possible to obtain, and they have a relatively high cost. So, when is molecular genetic testing required? This is a broad definition that when the possible result has the potential to be useful for patients and or their family. And of course, you have to take in account the available and the access of this exam for the family and the patients. So now I want to share another question to know your opinion about this subject. In your opinion, for which group of disorders do you consider genetic testing most likely to be useful? You can answer of that.
So thank you very much, Alex, for very nice guidelines, practical guidelines related to the possible genetic investigation of disorders of growth. And of course, the next, perhaps most common cause of referral is abnormal puberty. Abnormal puberty, either delayed puberty or precocious puberty, is very common in pediatric endocrinology. And before we go on, before I ask Anna Claudia to give her presentation, I'd like to remind you to post questions. You can do this throughout the webinar. Post questions, and we will attempt to address them. We will, of course, address them either during the interval between the presentations or anyway during the discussion period. So please don't forget to do that. And invite Anna Claudia to give her presentation on the investigation of abnormal puberty, genetic contributions. Thank you.
Thank you so much. It's a great honor to be part of this web seminar in São Paulo City, Brazil. Thank you very much for having me. And it's a pleasure to share this activity with my dear colleagues, Professor Martin Savage and Alex Jorge. Thank you. I do not have any conflict of interest, and I'm very thankful to Springer for supporting my participation. As you know, puberty is an essential biological process marking the transition from childhood to adulthood, and it's characterized by the appearance of secondary sexual features, acceleration of growth, and fertility. It can be affected by genetic, nutritional, environmental, and socio-economic factors. The initiation of puberty requires the involvement of many factors, which are organized into functionally connected network that affects various steps along the neuroendocrine cascade. In fact, during the prepubertal period, neurons secreting GnRH are subject to persistent transsynaptic inhibition, and when this inhibition is lifted, GnRH secretion increases, which leads to the onset of puberty. Candy system is one of them. It's involved in the fine-tuning of GnRH secretion. The candy neurons secrete kisspeptin, neurokinin B, and both are stimulatory factors. And dynorphin is an inhibitor factor. The role of candy system in humans is highlighted from the observation that loss of function mutations in genes encoding kisspeptin receptor, and neurokinin B are associated with congenital hypogonadotropic hypogonadism. It's known that genetic factors play a fundamental role in the time of pubertal onset, as illustrated by the similar age at menarche among members of an ethnic group, mother-daughter, monozygotic twins, and sibling pairs. In addition, it's very well known that gain-of-function mutations are associated with peripheral precocious puberty, such as testotoxicosis, due to constitutively activating mutation of the LHCG receptor gene, and also McCune-Albright syndrome, caused by activation of the alpha subunit of GSG. In addition, familial cases can occur in approximately 20% of pubertal disorders, supporting the idea of genetic role in their etiologies. Genetic investigation of patients with congenital hypogonadotropic hypogonadism implicated several genes in the reproductive axis. Abnormalities in genes implicated with development and migration of GnRH neurons, such as CAL1 and FGFR1. Also genes implicated in the hypothalamic secretion or pituitary actions were identified in patients with hypogonadism, hypogonadotropic hypogonadism. However, the progress of the genetic basis of central precocious puberty has been achieved much later than congenital hypogonadism and is still poorly understood. To date, 4 monogenic causes of central precocious puberty were established. Gain-of-function mutations of a gene encoding kisspeptin receptor, or GPR54, gain of function mutation of gene encoding the ligand kispeptin, loss of function mutations of the imprinted gene encoding macroin ring finger tree, or mkRNA3, and finally, loss of function defects of the imprinted gene encoded delta-like 1 homolog DLK1. mkRNA3 are the most prevalent cause of familial central precocious puberty nowadays. The role of mkRNA3 in the pathogenesis of central precocious puberty was first demonstrated in 2013 when whole exomic sequence analysis was performed in 40 members of 15 families with central precocious puberty. The great majority of the selected families were originated from Brazil, and we were able to identify 5 families with CPP who carried loss of function of mkRNA3 mutations presented here. All affected families had autosomal dominant inheritance, and they were consistent with the paternal transmission. mkRNA3 is an imprinted gene with expression only from the paternally inherited allele. It's an intron-less gene, a small gene, located on a complex imprinted locus in chromosomal 15q, a Prader-Willi syndrome critical region. More than 32 different loss of function mutations of mkRNA3 have been reported in patients with central precocious puberty, and a hotspot region has been identified at codon 162. The prevalence of these mutations in familial cases is high and has been described in European population up to 46% of the familial cases, while in sporadic forms of CPP, the prevalence was variable from very low of patients from Korea, 0.4, to quite high in males from Brazil, 17%. More recently, in 2017, we performed linkage analysis followed by whole genome sequence in an Afro-descendant Brazilian family in which 4 girls, including 2 sisters and 2 paternal half-sisters, had progressive and non-syndromic central precocious puberty. Puberty started around 5 years in these girls. Their paternal grandmother had history of menarche at 9 years old, and the children's father had normal pubertal timing, suggesting an imprinted disorder. However, this family had no mkRNA3 mutation. In fact, a complex genomic defect in a new gene called DLK1 located at chromosome 14q was identified in this family. Abnormalities of the locus 14q, including DLK1 gene, cause a rare and complex syndrome called temple syndrome, which is characterized by central precocious puberty in 90% of cases. In face of these recent genetic and clinical observations, we considered that both the the Brazilian family described here, and the syndromic CPP related to temple syndrome are associated with DLK1 deficiency. More recently, we identified 3 novel and rare frame shift mutations of DLK1 in 5 adult women from 3 unrelated families with central precocious puberty. Segregation analysis was consistent with the maternal imprinting of DLK1. It's well known that this gene, DLK1, prevents adipocyte differentiation, being considered an anti-adipogenic factor. Notably, metabolic abnormalities such as overweight or obesity, hyperlipidemia, early onset glucose intolerance, or even type 2 diabetes mellitus were more prevalent in DLK1 mutant adult female patients when compared to the idiopathic treated CPP group. Serum DLK1 levels were measured in affect members of families with DLK1 mutations and also in normal controls using ELISA assay. We demonstrated that DLK1 levels were undetectable in patients with DLK1 defects. Similar data was observed in patients with Temple syndrome who had barely detectable levels of DLK1. These findings suggest that this accessible biochemical measurement could be a potential screening assay for the diagnosis of syndromic or isolated CPP due to a deficiency of DLK1. Therefore, DLK1 deficiency is characterized by reproductive and metabolic alterations. And DLK1 is a novel link between reproduction and metabolism. Understanding the mechanism responsible for many rare and common diseases allow us to develop novel strategies for clinical approach, including target therapeutics, altering diet or behavior, prophylactic intervention, and increasing surveillance. These actions can deliver tailored care to individual patterns of genetic predisposition. Finally, genetic defects have been demonstrated in patients with central precocious puberty, increasing our knowledge about the factors related to the pubertal timing. Thank you.
Thank you very much indeed, Anna Claudia, for clearly setting out really the contributions of genetic investigations to abnormal puberty. Now we have some questions. Thank you very much for posting the questions, and we have some here. And I'd like to ask first Anna Claudia and then Alex. So Anna Claudia, we have a question which is for whole exome sequencing for pubertal disorders. Does one have to carry out whole exome sequencing for parents and siblings as well as in the patient?
Mm-hmm. Yeah, in fact, for all genetic disease, the ideal scenario is to study at least the patient with the disease and also parents. And it's possible to have affected and non-affected individuals from the same family in this analysis will be very useful for distinguish pathogenic mutations from non-pathogenic mutations. Then the possibility to study the family, especially parents and affected individuals, is very important to get positive results and reliable data.
Thank you very much. And a question to Alex. which children with idiopathic short stature would you study? Those particularly with severe short stature? Would you like to comment on that?
I think there is, for isolated idiopathic short stature, the decision to start a genetic investigation, I think we have to choose first children that have access of a genetic test first. The capacity to pay or to be reimbursement about the genetic test. The second, it's how the more severe short stature in relation of their parents, or more severe short stature in relation of population, increase of chance of monogenic conditions, or when you have a consanguineous parents or a clear autosomic dominant inheritance pattern.
Thank you very much. So one more question before we move on to Anna Claudia. You've had compliments on your presentation, with which I agree. Anna Claudia, excellent presentation. What genetic defect would you suspect, if any, in familial precocious puberty inherited from the mother?
Oh, okay. In fact, to date, we have only 2 genes linked to the father transmission. There is no knowledge about central precocious puberty with maternal transmission. And I'm looking now for new genes using whole exomic sequence or even genomic sequencing for discovery these potential genes, like genes associated with maternal transmission only, similar to that we have in MEK-RNA3 and DLK1 that are paternal transmission. But definitely there are several families that we have collected with maternal transmission, and we don't have a good gene now.
Thank you very much. Okay, I think, thank you very much for posting these questions. We have lots of interesting questions coming in, but I think we should move on. And so now it gives me pleasure to go back to Alex and introduce your presentation, Alex, on therapy of short stature genetic influences. Thank you.
Thank you, Martin. My disclosure again. And now, in this last part of my presentation, I will try to answer the following question. Should genetic findings be taken into consideration when planning short stature therapy with growth hormone? Can positive genetic findings influence the growth response to growth hormone therapy? And should mutations and the polymorphism be taken into account when planning and initiating therapy for short stature, such as with growth hormone? And should genetic findings be added to variables used to predict growth response to growth hormone therapy? In this scenario, the implication of genetic test in the decision of treating children with short stature, we have 2 different classes of children. First is children with a syndromic short stature, like this girl that born small for gestational age, that come to us to growth hormone treatment, and have a microcephaly and language development disorders and a high IGF-1 levels. In the opposite side of this spectrum, you have the children with isolated short stature, like this boy that also born small for gestational age and come to us to receive growth hormone therapy and have normal physical examination, normal development, normal laboratory assessment. For children with syndromic short stature, the genetic tests have give a clear important informations, like there is conditions where specific follow-up is necessary, like Turner syndrome. And the genetic tests also reveal conditions that increase the risk of cancer, like Bloom syndrome or Fanconi anemia, that is usually contraindications of growth hormone therapy. And the genetic study can diagnose conditions that predict a poor growth response to growth hormone therapy, like several skeletal dysplasias or patients that have growth hormone insensitivity or IGF-1 insensitivity. For children with isolated short stature that usually are classified as idiopathic short stature, ISS, or small for gestational age, usually nowadays we try a non-specific follow-up and treatment, and we can offer growth hormone therapy with a mild increase in height compared with non-treated children. This usually can be explained because several of these children classified as idiopathic short stature can present spontaneous catch-up growth during the puberty, like this study that assessed almost 300 children with idiopathic short stature at the age of 7 and followed then until the age of 23. Only 27% of these children with idiopathic short stature became short adults. And we don't know about which genetic marker can predict spontaneous catch-up or non-spontaneous catch-up. Well, in this sense, we believe that with the increase of genetic tests, we can identify children with isolated short stature that have genetic causes of short stature, different ones, and this can trigger a specific approach, indicate growth hormone or not even only observation. And even patients with the same genetic cause can have different approaches regarding doses or strategy to treat because different polymorphism variants that modulate the metabolism of growth hormone and other medications. We already know several genes that explain non-syndromic short stature. Each of these genes explain a small proportion of patients classified as idiopathic or small for gestational age. And these genes usually are related with genes that regulate growth plate or growth hormone or IGF-1 action. But we also have children that are classified as idiopathic short stature that have the mild phenotype of monogenic conditions, like these two boys that have a very mild facial features that have pathogenic mutations in the PTBN11 that allowed us to diagnose Noonan syndrome, a mild form of Noonan syndrome of them. And there is clear consequence of genetic diagnosis, not only related about growth in these children. Like children with Shock's defect, we know that they have an increased risk to develop Madelung deformity and the loss of height potential during the puberty. Also, children with AGRECAM mutations have a risk to develop early onset osteoarthritis. And the children with PTBN11 or NF1 mutations have increased risk of neoplasia, scoliosis, and an inadequate response to growth hormone therapy is frequently observed. And of course, there is a large group of children with a defect in growth hormone IGF-1 axis genes that increase the chance of a poor growth response during the growth hormone therapy. But even in children with a homogeneous cause of short stature, those with a severe growth hormone deficiency, you can observe a huge variability in first year response to growth hormone therapy or the adult height. We already recognize several clinical data that can explain the variability of growth response, like the growth hormone dose, mid-parental height, height at start therapy, and treatment duration have a direct proportion to growth response of children treated with growth hormone. And the age of start therapy is inversely related. But these parameters explain 30 to 60% of variability of the growth response in children treated with growth. For this reason, in 2004, when a first study analyzed a polymorphism in the growth hormone receptor, the absence or the presence of exon 3, in relation with the response to growth hormone therapy. After these first study that was focusing children with ISS as a small for gestational age. Several studies investigated this polymorphism regarding growth hormone deficiency and Turner syndrome and other indication of growth hormone therapy, as well other polymorphisms in IGF-1, GFBP3, in many other genes. Although it makes sense and the use of SNPs that predict the response to growth hormone therapy is a logical approach, at this moment, all the identified polymorphisms have a small effect. The studies are not completely reproducible, and there is the lack of prospective validations or evidence that they should modify the current treatment. For this reason, I can recommend that polymorphisms of the growth hormone IGF-1 axis genes should not be taken into account when planning and initiating therapy for short stature. But if a polymorphism is not needed to be taken into account, should I take into account other genetic defects? And I think the answer is yes. Like for both children that I showed in the beginning of this presentation, they go to whole exome sequence. And for the girl with syndromic short stature, we found a mutation that allowed us to diagnose rare conditions called floating harbor syndrome. And analyzing several children with these conditions, now we know that they have quite frequently a high IGF-1 levels, basal or during IGF growth hormone treatment, and several other aspects like increase of chance of cerebral malformation, central nervous system malformation. And for the boy, we have a pathogenic variant in NF1 that allowed us to diagnose neurofibromatosis type 1 diagnosis. That means that this boy have an increased chance to several neoplasia and have some cares, especially in the decision to start growth hormone therapy. My final conclusion, in my opinion, it's likely that with the increased availability of genetic testing, it may become the standard methods of investigation of children with short stature. And I like to quote Andrew Dauber that just wrote quite recently a comment, editorial in the GCM entitled "Genetic Testing for Child with Short Stature Has the Time Comes to Change Our Diagnostic Paradigm." He writes, if one is able to identify the genetic variant that is likely to be making a major contribution to the patient's short stature, the next questions become what can and should we do therapeutically and also for follow-up. The answer to those questions is quite complex and requires much more research in the natural history of individuals' genetic subclasses of short stature. However, we can only begin to answer those questions once we remove the word idiopathic from the diagnosis of short stature. So, to finish my presentation, I'd like to know your opinions for what is your greatest barrier to obtain a genetic test in your clinical practice. Thank you, Martin.
Thank you very much indeed, Alex, for some very clear guidelines related to therapy of short stature. Now, thank you for posting these questions. We have several questions. Some, I think, are more suitable to discuss during the major discussion period we have at the end. So I would like actually to move on now.
Okay.
And ask Anna Claudia to give her presentation on management of central precocious puberty.
Okay, good. Central precocious puberty results from the premature activation of the hypothalamic pituitary gonadal axis, and it mimics physiological pubertal development, although at an inappropriate chronological age, before 80 years in girls and 90 years in boys. CPP is considered a rare disease with clear female predominance. Its prevalence can be variable, ranging from 2.6 to 56 per 100,000 individuals. Different causes are associated with central precocious puberty, including congenital abnormalities, acquired conditions, and those without central nervous system lesions. In males at younger age, increase the risk of brain lesions, especially tumors. Diagnosis of CPP requires detailed clinical information and true physical examination along the support of hormone measurement and tests and imaging. The clinical history should include questions about the time and progression of the breast development, there is or not vaginal bleeding, pubic hair stage, testicular increase, growth velocity, and neurological symptoms and signs. Complete physical examination is essential, and it must include weight, height, BMI, growth velocity, abdominal palpation, Turner stage of breast development and pubic hair, testicular size, skin features, eye fundus in neurological examination. The skin evaluation can provide relevant information about the presence of androgen secretion, mosaic disorders, and metabolic alterations. Diagnosis can have 3 steps are usually necessary for obtaining a complete diagnosis of CPP after history and physical examination. First step include bone age, hormone profile, including gonadotropins and sex steroids, and generate stimulation test. The second step usually include brain MRI for exclusion hypothalamic lesions. And more recently, the third step can be the genetic studies, mainly in familial cases. CPP is diagnosed by the evidence of early and progressive clinical signs of pubertal development, accelerated growth higher than 6 centimeters per year, and advanced bone age more than 1 year in comparison with chronological age. Pubertal basal or stimulated LH levels indicate the activation of the hypothalamic pituitary axis. Brain MRI is mandatory for excluding organic form, especially in boys. In familial central precocious puberty, genetic studies could precede the brain MRI, which might be postponed in non-mutant cases or even avoided completely in patients who carry mkRNA3 mutations. The financial costs of the genetic analysis of mkRNA3, a very small gene, an intron-less gene, are much lower than the costs of the brain MRI in children who usually need anesthesia for this scan. Therefore, a reliable family history is a key element for driving the medical decision of whether to do a brain MRI or a genetic test. The gonadotropin values can widely vary according to the methods used for hormone measurement. Using monoclonal assays, LH levels higher than 5 units per liter after generate stimulate tests are considered the gold standard for the diagnosis of CPP. Brain MRI should be performed in all boys less than 9 years and girls less than 6 years. Girls between 6 and 8 with CPP and neurological dysfunction should also do brain MRI. It's controversial MRI in girls with this age, 6, 8 years, because there are low prevalence of lesions in these patients. It's important to know there are limitations in the study, especially the need for sedation, administration of intravenous gadolinium, and it's an expensive exam. Around 10% of the CPP cases can have incidental findings, such as pituitary microadenoma and pituitary hyperplasia, that are not causes of the central precocious puberty. The differential diagnosis of CPP include peripheral precocious puberty and common pubertal variants of normal puberty, such as premature TELAC and premature Latronico. Among the consequences of precocious puberty are the loss of potential adult height, behavior and psychological problems, cancer risk, especially breast cancer related to the premature and long estrogen exposure, obesity and increased cardiometabolic risk. Generate analogs are the gold standard clinical treatment for CPP. They act as a competitors of endogenous generate, binding with higher affinity and longer lifespan in the pituitary transmembrane generate receptor, a G protein coupled receptor, leading to the receptor internalization, a down regulation, and consequently reduction of biological action of GnRH and low synthesis and secretion of gonadotrophins. There are different GnRH analogs with multiple dosages, and there is no uniform consensus of the best way for monitoring CPP treatment. I think it's important to know that the outcomes that we expect are to arrest the pubertal progress, decline of the growth velocity, and decrease of bone age advancement, preserved adult height. There is no uniform consensus of the best way to monitor CPP patients, but it's important to include physical examination and oxologic parameters, periodic bone age, and basal or stimulated LH levels. The best results are achieved in patients with CPP diagnosed before 6 years and 9 years in girls and 9 years in boys. Among the factors associated with better adult height are early age at start of puberty, younger bone age at diagnosis, short interval between pubertal onset and starting treatment, elevated height at diagnosis, and greater target height. In girls with puberty onset between 6 and 8 years, it's important to individualize the treatment, take into consideration the prediction of menarche age, parental adult height, target height, parents' opinion, and patient's psychosocial maturity. GnRH analog treatment is considered very safe with more than 30 years. And because of that, side effects are uncommon, fortunately, including headaches and hot flushes, skin reactions, and vaginal bleeding after first injection. Stopping GnRH analog treatment at age 11 and bone age of 12 has been associated with greatest gain in adult height. Usually, men and girls begins 2 to 6 to 1 month after stopping treatment. Regarding the long-term data, we know that there is lack of negative influence on body mineral density and reproductive. However, potential increase of BMI and higher prevalence of polycystic ovary syndrome can occur. Thank you very much, Martin, for this opportunity.
Thank you very much indeed, Anna Claudia, for a lovely presentation, very clear clinical guidelines. So we now come to the time when we can answer some of your questions and look at the results of the polling multiple choice questions. Let me just give a summary in one slide. And that is, as you all know, in the 1980s, the molecular revolution started to have a real impact on our knowledge of pediatric endocrinology disorders. So over the last 30 years, and we are now over 30 years since molecular investigations really made an appearance, essentially our aims are first to discuss the genetic advances in the fields of growth disorders and puberty disorders, and this is what we've done with beautiful presentations today. And secondly, really to see how these genetic advances can be used to positively contribute to the understanding and management of disorders of growth and puberty. This is the challenge of translational medicine, to apply scientific progress to patient care. So let's open some of the discussion now. And first, I think we can start to look at the results of one of the polling questions, which is actually interesting because the question was, what is your greatest barrier to obtaining genetic testing? And please select one of the options. And there are actually 3 clear results here. The first barrier was reimbursement. The second barrier was knowing which test to ask for. And the third barrier was to know which laboratory to send your DNA to. And I'd just like to ask Alex and Anna Claudia, as clinicians, often we're really in the dark. And I think, would you agree that one point which is important is that we need to build a relationship with the genetics laboratory, the people we're sending the DNA to. Pick up the phone, ask them, try to build a working relationship with them. And in that case, these results will be answered, which test, which laboratory, and also the interpretation of the results will be much simpler. Would you agree, Alex? Do you like to comment?
Completely. And especially because when we are conducting a genetic analysis, it's very important to know about the clinical data. It's impossible to make an analysis of a panel or a whole exome sequence without the clinical data. Yes. All information that you can give for the laboratory, it's very useful. I think in South America, we saw in São Paolo quite recently a huge increase of number of laboratories that offer genetic tests. And I think this will follow the same in the other parts of Brazil and other cities of South America, but we still have a delay to laboratory that can offer the test to be available in some parts of our continent. And the same happened with the private health insurance that still are not always reimbursement the tests, but they start to be more often and more common.
And Claudia, from the point of view of genetic tests in abnormal puberty, do you think it's important before you actually make the decision to take DNA and to send it to the laboratory, perhaps to contact the laboratory, ask them if they have experience in looking at the particular gene you're interested in, or whole exome sequencing? Can you comment on that?
Yes, I totally agree with you. That's very important that the clinician can be more close to the laboratory in all aspects, not just the genetic, but the hormone data. If there is any doubt about what's the cutoff of LH to distinguish prepubertal to pubertal, I think it's very important to have a nice communication between clinicians and the laboratory people working in hormone measurement and genetic tests. And in pediatric endocrinology, I think it will be impossible to avoid genetic information nowadays.
Yes.
Because we are living a new era with novel genetic diagnoses in growth disorders, in pubertal disorders, and I believe, Professor Martin, that it will be more in the next years, more data, more information about disease in pediatric endocrinology with genetic basis.
So things are going to get even more complicated in the future.
It's true.
I can tell that. Now, Alex, I have a question for you. And this really is the place of genetic investigations in the assessment of a child with short stature. We have a question: how do we assess a male child aged 3 years who has a height of a 1-year-old child? Intelligence is normal and there is no parental consanguinity. So how do you place genetics compared to clinical assessment or endocrine assessment in the investigation of this particular patient?
With isolated short stature.
3-year-old child with the height of a 1-year-old.
Well, I think first, if you have a more complex phenotype, intellectual disability, a development delay, I know that beside the fact that there is no consanguineous parent in syndromic children with no specific finding that can trigger a clinical diagnosis, the use of a whole exome sequence can help to reach a diagnosis for recessive disorders or autosomic dominant one that at least have impact in genetic counseling of the family and can have also a lot of information that can help the children. For children with only short stature as a unique phenotype,
yes.
I think at this moment we have to follow our traditional guideline. Clinical assessment, laboratory assessment to looking for chronic disease, assess of growth hormone axis especially.
Yes.
And of course, for children like that we are planning to decide to go to growth hormone therapy and have short stature without other findings, if he is a girl, you ask her karyotype.
Yes.
As a boy,
yes.
They could have a mild form of non-syndromic or other conditions. It's a matter of if you have access of the exam and discuss with the parents the impact of the results, you can order a panel, not a whole exome in this moment.
Right.
I think for syndromic short stature, whole exomic or targeted gene approach.
Yeah.
For isolated short stature, I think a panel that rule out the most important conditions that are associated with this phenotype, like Nuna or growth plate disorders, like that.
Okay. But to the person who kindly asked the question, let's not forget that we are clinicians. Mm-hmm. And as Alex said previously, the interpretation of any genetic result can only be done with a detailed knowledge of the clinical phenotype. So don't let's forget, as clinicians, we need to go back. We need to take a history. We need to examine the patient carefully, take time to see if there are any subtle dysmorphic features. Look for general pediatric conditions, which can often be missed, celiac disease, Crohn's disease, for example, and then go ahead with endocrine investigations, growth hormone assessment, measurement of IGF-1, because these are important, and they will be even more important when we get the result of a genetic investigation in that particular child. So let me, Alex, I'm going to ask you another question, because there's a good question here, and that is the dose of growth hormone which is used and which is indicated for a child with a genetic growth disorder.
Well, it's depend what kind of genetic growth disorders do you find. Like for a child that you found a IGF-1 receptor mutation that causes a partial IGF-1 insensitivity, you can expect that this child will have high IGF-1 levels. And usually we decrease the dose of growth hormone when we observe a high IGF-1 levels. For these particular children that have IGF-1 sensitivity, we can consider that high IGF-1 levels is what you want to pursue during the treatment.
So how high would the dose be? I mean, what would be the maximum
I think
dose?
Around 2 standardization score. I don't feel comfortable to let above 3 standardization score, even in the IGF-1 insensitivity. Sure. But for children that have a genetic defect, like in growth plate, I don't know if I change my recommendation of go to growth hormone dose regular, look at the IGF-1. If you have a high IGF-1 levels and a poor growth response, I don't recommend to increase growth hormone dose. I recommend more. It's not a responsible cause of short stature responsible to growth hormone. I think it's better to decide to stop the treatment.
Right. So a critical approach as to whether the child really is responsive to growth hormone or not. And I would just add that the height velocity during the first year of treatment will give a very good guide to the degree of responsiveness of that patient to growth hormone. So Anna Claudia, let me come to you now, and an important question. Do you have data on the chances of reproductive impairment in adult life in children with precocious puberty?
Yeah. There are papers showing that the reproductive life is totally normal in patients with central precocious puberty who were treated or not.
Yep.
Apparently, there is no reproduction alteration in these patients. However, I wanted to mention that in one family with DLK1 mutation, 2 sisters had polycystic ovarian syndrome with infertility and hyperandrogenism. And we have, it's only 2 cases among 10 described so far. We have the possibility that DLK1 mutations are also associated with polycystic ovary syndrome and metabolic diseases.
Okay,
that is a very, how can I say, special situation.
Yes, a special situation. But let me ask you a general question about transitional care and adult follow-up. You have a child with apparently idiopathic central precocious puberty. You've treated the child successfully. She has an acceptable adult height. She's come off her GnRH analog therapy. Her puberty has progressed normally. Would you discharge her from medical care, or would you continue to follow her up in adult life?
Yeah, I think I have a very special situation because my division, my institution, I am able to see children and adults in the same outpatient clinic.
Yes.
Then we try to follow more than we at least 5 years after the MNOC, we still follow the patient. But I think it's important to inform the patient that in the future, when he or she come to the medical doctor, please mention that you had central precocious puberty.
Yes.
Because could be important for maybe breast tumors, metabolic alterations. Then, in fact, I think it's very nice if you have a long-term outcome of patients with central precocious puberty and communication between pediatric and adult endocrinologists in this action.
Okay, I mean, I can understand that you have an academic interest in looking at the life history, the natural history of central precocious puberty. But I think it's very good advice that essentially you can give patients perhaps their own medical records, that if they present later, they can inform their general practitioner that they've had this history. Okay, we're coming to almost the end. Let me see any difference in the response to GnRH analog in a patient with a genetic defect as the cause of their precocious puberty or idiopathic? Just perhaps a brief response.
Very important question. We just published in Neuroendocrinology Journal the long-term data of patients with central precocious puberty with MEK/RNA3 mutations who were treated. And there is no distinguish between patients with MEK/RNA3 and idiopathic CPP. The same satisfactory response to GnRH analogs was observed in both groups.
Okay, that's very, very helpful. So I'd like to thank you, the audience. Thank you for logging in. It's been a pleasure to share this time with you, and we hope very much that you have found this a helpful and an instructive webinar. I'd like to thank Anna Claudia and Alex very much indeed for your excellent presentations. And just to remind you that please remember to complete the evaluation form, which will be directed to you at the end of the webinar. And also, if you didn't manage to listen or stay for the whole webinar, of course, an on-demand video will be available on the Springer Healthcare website, pediatric endocrinology website, in the next 2 to 3 weeks. And you will receive an email from us when it is online. Finally, thank you very much indeed for participating, for logging in, and for your interesting questions. Thank you and goodbye.